Hello, I am Kurt Muller from the Department of Health and Human Services, Office of Inspector General. Our mission is to protect the integrity of HHS programs and the health and welfare of their beneficiaries. Today, I'm pleased to speak with you about OIG's overall efforts to address the opioid epidemic and to highlight the work of OIG's Office of Investigations. I also encourage you to watch the companion videos which detail other aspects of our work and in which we make suggestions you can take to contribute to the fight against opioid misuse. As you know, the opioid epidemic is a national public health crisis impacting individuals, families, and communities across the country. American Indians and Alaskan Natives have been particularly hard hit by this crisis. According to a recent article in the Washington Post, from 2006 to 2014, Native Americans were nearly 50% more likely to die from an opioid overdose than non-natives. Between 2016 and 2017, American Indians and Alaskan Natives experienced a larger percentage increase in deaths related to prescription opioids than any other racial ethnic group. Several factors contribute to the recent increase in opioid misuse among tribal communities. First, there have been an influx of opioids shipped to these communities, exceeding the national average of pills per person. In fact, the number of opioids provided to tribal communities is in line with the amounts distributed to the Appalachia's opioid belt. Second, tribal communities tend to have high rates of employment in dangerous industries such as farming, logging, and fishing. Injuries from these industries often require pain management and treatment. The opioid crisis has had a devastating impact on many American Indian and Alaskan Native communities, not only in terms of population health, but also impacting law enforcement, foster care, and other social services in heavy demand in communities struggling with addiction. This is a tremendous burden for many tribal communities, and OIG is committed to helping. How does OIG assist in this fight, you might ask? Addressing the opioid epidemic is a top priority for OIG. Our efforts to address the opioid crisis has three main components. First, we focus on identifying ways to improve the efficiency and effectiveness of HHS programs, such as the Indian Health Service. For more on our work to improve opioid prescribing and treatment in IHS, please refer to our companion video, OIG Studies on Management, Prescribing, and Dispensing of Opioids in IHS and Tribal Facilities. A second area of focus is empowering and collaborating with partners through data sharing and education. Be sure to watch the companion in this series entitled Using Data to Assess and Evaluate Trends for more details on our opioid analysis toolkit. Finally, OIG works to protect the health and safety of HHS beneficiaries by finding and investigating potential fraud involving prescription opioids ranging from prescription drug diversion to addiction treatment schemes. In our Office of Investigations, which we call OI, we have 600 employees nationwide with 500 criminal investigators, along with general investigators, forensic computer examiners, and a variety of analysts and assistants. We conduct investigations of fraud and misconduct related to HHS programs themselves and their operations, as well as their employees and contractors. Much of our work comes from referrals from our hotline, state, local, and tribal agencies, and the Indian Health Service. And our investigations generally are collaborative efforts. We work often and closely with the DEA, FBI, BIA, and state, local, and tribal law enforcement, to name a few. However, it's important to note that we are not just about investigating fraud after the fact. We also play a key role in supporting education to prevent fraud before it happens. I'd like to take a few minutes to talk about the problems of drug diversion, what it is, and how we can work together to address it. Drug diversion is when prescription drugs are obtained or used illegally. In other words, diverted from their lawful purpose into illicit drug traffic. Unfortunately, drug diversion is committed through a wide variety of schemes. Medical providers or pharmacists, for instance, might divert drugs for illegal distribution or for their own self-medication or abuse. Employees may steal drugs or there may be a burglary or even armed theft of drugs from pharmacies. In still other cases, patients may go doctor shopping, which is visiting multiple providers to obtain multiple prescriptions or forge or alter prescriptions to get illegal access to drugs. The problem of drug diversion is especially challenging because it can occur anywhere in the supply chain, during transit, in the wholesale warehouse, at pharmacy receiving, and once in the pharmacy. Efforts to address drug diversion should start with prevention and deterrence. So what can you do? In our work, we found a number of measures to be helpful. First, keeping a perpetual controlled substance log, a record book to track the flow of controlled substances into and out of a pharmacy. This log, mandated by DEA, helps to identify discrepancies between the amounts listed in the log and the actual count of the controlled substances in the pharmacy. Daily reconciliation of controlled substance activity also is a best practice, and 2 signatures should be required for logging controlled substances in or out of inventory. In addition, if you don't already have them, electronic surveillance cameras should be considered for the pharmacy. Separation is another way to prevent diversion of prescription drugs. This includes separation duties for ordering and receiving controlled substances, as well as separating controlled substance activity to a defined area in the pharmacy and storing controlled substance prescriptions in locked cabinets to which only authorized personnel have access until dispensing. Electronic controlled substance safes allow for around-the-clock monitoring of access. Other important prevention measures include use of video recordings, alarm systems, return to stock protocols for prescriptions but not picked up by the patients, and including only 100 count or less bottles of bulk controlled substances to prevent large thefts. If you have not already done so, you might also consider a range of physical and security system measures described in the IHS Manual, Part 3, Chapter 7, which IHS facilities are required to follow. You should also be aware of other things that can make your pharmacy more vulnerable. Having a pharmacy in an isolated location is risky, as is having a wide range of staff familiar with the pharmacy layout and operations. Staff shortages and use of contract staff can also make you vulnerable. Be sure to take steps to limit these risks if possible. Of course, prevention efforts are not always 100% successful. When they are not, and illegal diversion is suspected, OIG's Office of Investigations and many partners are often called in to investigate. In the National Healthcare Fraud Takedown, for example, OIG and its law enforcement partners worked to charge 601 defendants for opioid-related fraud related to prescription patterns and patient treatment. Of those charged, 168 were medical professionals, including 32 doctors. This and other takedowns send a strong message that theft from federal healthcare programs will not be tolerated. I should mention that healthcare fraud schemes can go viral with criminals learning fraud techniques from other offenders. HHS-OI and our law enforcement partners work to shut down fraud quickly and responsibly. In one noteworthy example, a North Dakota tribal member and his wife were charged with conspiracy to distribute opioids embezzled from an Indian Health Service pharmacy. 2 other co-conspirators in this scheme were also charged and convicted after they sold prescription drugs on the streets of the reservation for their own financial gain. A total of 5 individuals were charged and convicted in this investigation that involved over 50,000 opioid tablets being stolen and sold in a North Dakota reservation. In another scheme, Pennsylvania Treatment Center conspired with physicians to supply pre-signed blank prescription slips to non-physician staff who then wrote illegal prescriptions for opioids to patients who were not first examined by a licensed doctor. OIG uses several weapons to enforce fraud laws: criminal, civil, and administrative. Some examples of our criminal enforcement are provided here. OIG also can exclude individuals and entities from participating in federal healthcare programs if they are convicted of certain criminal offenses, including convictions related to controlled substance for individuals connected to the healthcare industry. I've provided some instances here for examples of both criminal enforcement and exclusions. Refer to our website at www.oig.hhs.gov. Taken together, OIG's three-pronged efforts advance prevention, detection, and enforcement of fraud, waste, and abuse, while ensuring quality care and treatment for those needing services. Fighting the opioid epidemic in American Indian and Alaskan Native communities and beyond remains a top priority for OIG. As we band together to address this terrible problem, we encourage you to incorporate the suggestions provided here and to learn even more about how they can help from the following resources.